So diabetic papillitis is the topic for today, and what that means is itis, but not inflammation. Itis meaning edema, but because papilledema means the increase in intracranial pressure, that's why I got stuck with this word papillitis, even though it's not really inflammation. And of course, diabetes, and it can be diabetes type 1 or type 2. It's a diagnosis of exclusion, and the reason it's a diagnosis of exclusion is there's no biomarker. There's no way to prove this is diabetic papillitis. There's no imaging study that can be done. So all of our traditional tools, ultrasound, OCT, MRI, none of those are going to be able to answer the question, is this disc swelling from diabetes or not? And so you have to work it up for the other causes first, and then it becomes, oh, that was diabetic papillitis. However, there are some clinical features that suggest it's diabetic papillitis. First of all, they're usually asymptomatic and their acuity is usually good, and they don't really have a field defect, or they just have a slight enlargement of the blind spot. So we're going to have to do the regular things of field and check their acuity. The OCT is going to be consistent with the papillitis, and they have diabetes. Well, that could be non-arteritic anterior ischemic optic neuropathy if it's unilateral. And so some people believe that diabetic papillitis is just a form of less severe NAION. And so it just depends whether you're a lumper or a splitter. If you're a lumper, diabetic papillitis might be just a less severe form of NAION. However, when it's bilateral, it's a lot less likely to be NAION and more likely to be a systemic thing. And in that setting, the thing you're trying to get rid of is papilledema. And so if it's bilateral, you're going to have to image this person, and that's where the imaging does help. So if you image papilledema, we might see the radiographic findings of increased intracranial pressure, fluid in the sheath, flattening of the globe, empty cella, MR venogram showing stenosis. That's going to be pushing you towards papilledema, even though the person is diabetic. So we would not call that person diabetic papillitis. We would say, oh, that's probably papilledema, and a lumbar puncture is going to be performed to measure the opening pressure, just like you would any other papilledema patient, with or without diabetes. So in summary, diabetic papillitis is edema of the disc, which we can see, papilla, in a diabetic patient. There's no real way to evaluate this in terms of the differential. You have to work it up, and therefore it's a diagnosis of exclusion. However, in my experience, one of the things that's helpful is there's these telangiectasias that are prominent on the disc, and so it kind of looks like big edema without any vision loss. So big edema, minimal vision loss, diabetic, that one's more likely to be diabetic papillitis. Bilateral more than unilateral is more convincing, but it can occur unilaterally. Normal acuity, normal field. These are the things that are going to make you say, this looks like diabetic papillitis. The presence of the retinopathy doesn't help at all. Could be there or might not be there. And so it's determined by whether you're a lumper or a splitter.